majority of us, we don't sleep enough, but they do not see any symptoms or repercussions from having a short sleep. We're gotten used to decades of ignoring the symptoms, decades of misleading diagnosis, decades of just waiting. I think if you are tired, waking up with headaches, or you get tired throughout the day as the day goes on, or you're questioning, it's like, hey, I used to be this energetic person. Why is now all of a sudden I'm dragging through life? All you have to do is just take the first step and believe there are some answers that could be found. There are all kinds of sleep labs and sleep clinics around you that could be a game changer for your performance, not just at work, but with your family life, with your overall sleep quality.
Welcome back to the Hidden Sleep Disorder Show, where we uncover the science, diagnosis, and treatment of sleep disorders that often hide behind chronic fatigue, poor sleep, and unexplained exhaustion. And today we're taking that conversation a step further, because one of the most surprising realities in sleep medicine is that many sleep disorders go undiagnosed for years. Some patients spend a decade or even more searching for answers before finally receiving the right diagnosis. So why does this happen? And what kind of sleep disorders are most commonly missed? So, Dr. Saini, let's start with the big picture. It's great to see you again, by the way. Are you excited for this episode?
I am. Thank you, Leila. And I want to dedicate this episode to all the short sleepers in the world. You know, the influencer who goes to bed at 12 and wakes up at 5, or the farmer who wakes up really early morning, or the, city commuter who wakes up early, but they do not see any symptoms or repercussions from having a short sleep, because majority of us do if we don't sleep enough. So this episode is dedicated to all the short sleepers in this world, which is a minority population, by the way.
Amazing. A minority population, but I'm sure a lot of people are still affected by it. And so I want to hop into it with your experience. So, in your experience as a sleep specialist, how common is it for patients to live with sleep disorders for years before they're properly diagnosed?
Actually, it's not even years. We're gotten used to decades of ignoring the symptoms, decades of misleading diagnosis, decades of just waiting, decades of where I just keep blaming something else for explaining my symptoms. And sometimes it's not just the people or patients themselves who are, maybe self justifying that, oh, I'm just like this, because I don't know any better. Or their family members have over time sort of made it so that, oh, one of my kids is just a lazy kid, and that's what these folks have to deal with day in and day out. So it just sort of gets ingrained in the DNA, so to speak, that, hey, that's what it is. So it's really fascinating when I talk to my patients and they are like, hey, I've been having these symptoms since my high school, since my early college, and I'm seeing them in their 30s, 40s, 50s, 60s. The biggest one I've seen, the gap, is someone who's having symptoms pretty much all their adult life. And then we're finally making some diagnosis. So I have two actually. I have one 70-year-old and I have one 91-year-old. So, it's incredible long wait time. And that's what we're hoping to change, Leila, with you and me talking about this, that hopefully we could reduce these wait times from decades to maybe just few weeks.
Absolutely. No, it's incredible. We touched on it last time about how it's so commonly misdiagnosed because you could always think it's something else, or there's so many things that people could think the issues are without it being a sleep disorder. But it almost seems like sleep disorders could potentially be identified quickly from a for doctor's standpoint. But why do you think so many sleep disorders are overlooked or misdiagnosed to begin with in the first place?
I'll give you two examples of how sometimes it plays out in the real world. One is where I'm not seeking any help because I'm ignoring my symptoms, or I keep coming up with some weird justifications in my head that, oh, I have depression maybe, or this is, in my family, my mom does that, my aunt does that, so maybe that's what it is. So that's patient angle, where I'm just, coming up with some random explanations and not really even seeking help. But the even the worst piece or scenario is where I go and seek help and actually see a clinician, but then they fail me. They fail to identify that, okay, I'm dealing with a sleep problem. And I'll give you a good example. I had a patient, she was actually went to her primary care physician and they sent her to get some sleep testing done. But unfortunately, where she went, they just basically ruled out sleep apnea, and they told her, hey, your sleep study is negative, you don't have sleep apnea, go home, nothing more we can do about that. Now, this could not be farther than truth, because hey, we have so much avenues, we have so many ways to tackle and come up with, at least determine what is the burden of sometimes sleepiness is how we use the word to measure the burden of all these symptoms in these patients. So there are several ways, but those two common scenarios I often see. The other example that comes to my mind is I have a psychiatrist, because let's say a lot of us have comorbid depression or anxiety. And then these clinicians keep blaming their comorbid conditions. For example, if I'm a diabetic, oh, you must be tired because you have diabetes, or oh, you must be tired because you have depression, or you must be tired. And they keep tweaking those medications, and that is a big factor in delay. So, as a clinician, we have to keep sleep disorders at the forefront when we're trying to think, okay, what are the differential diagnoses? Because a lot of clinicians think that way, that, okay, what are the main reasons for this possible symptom and how could I explain it? But generally, sleep disorders do not make it to that list when they're analyzing, when they're thinking. So we need to change that. And, only way to do that is by educating the masses so they can talk about this.
Absolutely. And when we were talking about things that are commonly misdiagnosed, depression is one of the things that came to mind because I'm sure that that's really common one. And you also mentioned sleep apnea. And I think that when most people think about sleep disorders, sleep apnea is top of mind as well as insomnia. What are some sleep disorders that many people have never really heard of, but you see regularly within your practice?
So I kind of try to divide these in few simple buckets. So either these are conditions where I am extremely sleepy and tired during the daytime, and then I'm trying to discover what is the underlying reasoning behind it. It could be sleep disorder breathing. And when we say sleep apnea, a lot of times people don't realize there's more than one kind of sleep apnea out there. When most of us are having a conversation about sleep apnea, we're only talking about obstructive sleep apnea. But there are central sleep apneas, there is mixed sleep apnea where you have features of both obstructive and central. So even just in that sleep apnea bucket, there are all different kinds of sleep apnea that one could be tackling. So that's a one big one. And then other ones, obviously narcolepsy is a big one. And then we don't, sometimes we don't realize even narcolepsy has two different types. There's narcolepsy type 1, there's narcolepsy type 2, depending on your clinical presentation. And then there is idiopathic hypersomnia, which is a fancy way of saying that, hey, I don't really know why you have hypersomnia, which means excessive sleepiness. But even though we have it labeled that way, we actually have pretty set diagnostic criteria to diagnose someone with this condition. The other one that comes to mind, Leila, is it's called Kleene-Levin syndrome, which sometimes we see it in younger people where they go through this phase of they are excessively sleepy, but along with being sleepy, they are excessively hungry, so they're just eating all the time, and they're hypersexual, and so they have a lot of sex drive happening, and it affects them for several weeks, and then it goes away, and then it shows up again. So it almost kind of goes into these cycles throughout the year, or whatever short span of time you want to look at. So it comes and goes. So that can make it extremely hard to even consider this, because then a lot of times people are thinking, hey, you're probably going through bipolar mania, depression kind of syndrome. So a lot of times there is overlap between these. And, if you're not really paying attention, you can easily miss some of these conditions.
That's so interesting because, well, I had never heard of that disorder, so that's really interesting. But you touched on the ones that are more common, for example, like sleep apnea and narcolepsy, but I didn't know that there were different types either. I thought sleep apnea was sleep apnea, narcolepsy was narcolepsy. And speaking about narcolepsy, I think it's one of the conditions people recognize by name. Everyone's heard of it, right? But I think it's pretty common that people misunderstand it, probably myself included. So, what are some of the misconceptions that people have about narcolepsy?
So narcolepsy is a very tricky condition. And why do I say that? Because the pop culture image of a narcolepsy person is someone having a conversation, and next thing you know, they're sleeping or collapsing on the floor, on the couch, whatever, which is not what we see in real world clinically, unless it's an extreme case of narcolepsy, which is very, very rare. Most sleep clinicians, even who just do sleep medicine, don't encounter those cases very often. In most cases, it's extremely subtle, and sometimes they could be living fairly what you would consider a normal life. They could be high achievers in college, in their education, or at work, but still they're paying a big price because they're constantly having to manage their narcolepsy symptoms.
So, another condition that many people have never heard of, myself included, is idiopathic hypersomnia. So, can you explain a little bit about it and why is it so difficult to diagnose?
So, idiopathic hypersomnia, as the name suggests, that we don't really have a clear understanding of the mechanism of this condition. Now, in contrast, if I give you the example of narcolepsy, we already know in quite a lot of detail at the molecular level what is happening in the brain. Because what's happening in narcolepsy is that for whatever reason, our orexin secreting neurons, brain cells, are getting destroyed in the brain. So there is lack of orexin, and we can even test you for orexin levels in your body, okay? Even though it's not a very popular test because it includes spinal tap. So no one wants to really get that done. But still, there are ways to test it. But there is no such testing or lack of chemical that we could at least pinpoint yet. Maybe in the future we will, but at this point, we don't really have any understanding of the basic pathology that would cause it or trigger it. But what we do have is very clear understanding of what these patients deal with, and that is a very prolonged sleep time in some cases. And then there is this always, they're in this brain fog, or they have what we call sleep inertia, meaning they wake up and it takes them forever to get going. So that's something we talk about them when we're trying to clinically identify this. And then on top of that, we have pretty set diagnostic criteria, but it's a condition of exclusion, meaning I have to rule out every other thing that could possibly explain these symptoms. So that means I got to rule out sleep apneas, all different kinds. I got to rule out narcolepsy. I got to rule out restless legs, any other sleep disorder before I label somebody that, hey, you may have idiopathic hypersomnia. So, as a clinician, we have to be extremely thorough in our evaluation and testing to come up with that. And that's what makes it challenging. Because if you're super busy or not paying attention or not listening to what your patient is telling you, then it can be easily missed or mislabeled.
Absolutely. And just even from what you just said now, and obviously I'm not a clinician, but that almost sounds like it could be misdiagnosed even with like ADHD sometimes, because I know that's big when it's people have a really hard time rather, getting up and get going and boggle down for different reasons. So that's probably confused for that too.
I'm glad you said that because I cannot tell you how many ADHD patients I see who actually just got that label because they couldn't focus because, hey, I'm sleepy, I'm tired. So it's much easier to just call it ADHD versus trying to actually figure out the underlying problem. So I see a lot of kids, I see a lot of adults who are being treated for ADHD, but then their underlying problem is actually something else. It's hidden.
Yeah, and exactly. And this could be completely wrong or off topic, but idiopathic epilepsy is a thing too, right? Is that related at all?
Right. So idiopathic in medical terminology, it gets used all over the place. So all different specialties, when they cannot make sense of a condition, they label it idiopathic,
Okay,
which is basically means I don't know the exact reason behind it, you
got
know?
it.
So there are all kinds of like neurologists could use idiopathic. So all kinds of conditions will have this term. But we're using it in the context of hypersomnia, which we have pretty set criteria to diagnose this, which makes it actually easier, not harder as a clinician, because all you got to do is, if you meet all the criteria, then here you go. You
Mm,
got your diagnosis.
And like you said, you have to rule out other things for it too. I think also another reason that sleep disorders are probably missed is that, like you touched on, symptoms often overlap with other conditions. So, what are some other health problems that sleep disorders sometimes do get mistaken for?
So, Leila, I used to also have primary care training before I switched to sleep medicine. And I cannot tell you how many patients that primary care physicians see in their offices, right? Because they have a broad spectrum of people coming to see them. People with diabetes, people with heart disease, people with brain diseases, stroke, Parkinson's, people with kidney problems, people with mood disorders. In fact, primary care physicians treat more depression than psychiatrists does in this country. Okay,
Wow.
so they're actually the first line for majority of the medical conditions or sickness that people deal with. So most of these patients and all these conditions that I just mentioned, they are linked at some level where patients are complaining that I'm tired, I'm not feeling rested, I'm fatigued, or I'm sleepy. And generally, they'll use the combination of some of these descriptors. Not most of them use the term I'm tired, fatigued, and a lot of them will actually, when you actually look deeper, they're actually very sleepy.
Yeah, no, that's interesting. And beyond that, too, when someone actually does finally see a sleep specialist beyond, a regular primary care doctor, testing often becomes part of the evaluation. So, how do sleep studies help really uncover the disorders that might be otherwise overlooked or missed?
That's a great question because without the testing, we're basically running blind and we have no clue then at that point what we're really getting into. So, what sort of testing uncovers some of these conditions that we talked about? For example, let's look at sleep apneas first, all different kinds of sleep apneas, because the testing has come a long way, especially for sleep apneas. It used to be all located in the sleep lab or in the hospital, but now a lot of the testing has moved into patients' home. So we do a lot of home sleep testing to uncover, especially if you are a high risk for sleep apnea. So who would that person be? Someone who already has other metabolic conditions like diabetes or high blood pressure. Someone who's male in their 40s or 50s. Someone with a higher BMI. Anytime my BMI is more than 30, my risk for sleep apnea goes up. So those are some of the folks that are high risk. So then it's much easy to offer them a home sleep test and get that done quickly because one, it's very convenient, it's easy to do, and you could even do multiple nights in the patient's own home, their own comfort of their bed. So that's one way to test it, which a lot of the times that will be the first test that patient will undergo to rule that out. But there is downside, and there are several different home sleep testing devices. If you searched online, you would probably come across 10 or 20 different tests that are potentially claiming to be home sleep tests. So the user has to really know, as a clinician, I have to really be well aware of all the ins and outs of this home sleep test device that I'm using. What are its strengths, what are its limitations? For example, some of them can underestimate my sleep apnea and come back falsely negative. And we see in practice sometimes what will happen is patient will do a home sleep test that comes back negative, and then there is no follow through on that. There is no follow up testing to confirm that, hey, did we miss it? Was it true negative or was it a false negative test? So that's a little bit of a limitation of the home sleep testing, I would say. And so that takes us into in lab sleep studies, because that's what we use for confirmation. That's what we use to confirm these different sleep disorders. And then, of course, in lab sleep testing is not just one test, depending on what we're trying to discover. For example, if our sole focus is sleep apnea and what is your breathing doing in your sleep, then we bring them in the sleep lab, have them spend a night, and generally we're looking at their breathing, we're looking at their sleep structure through their brain waves, we're monitoring their heart rhythm through EKG, we're monitoring their muscle tone, and see if they're grinding their teeth, if they're being restless, if they're moving their legs. So it's a much more holistic, much more detailed data capture for all the physiological signals that we're dealing with at nighttime. So that is the in-lab sleep study that is focusing on ruling out sleep apnea, but it can also pick up, for example, if I'm sleeping and in my dream I'm starting to act out on my dreams. I just saw a patient actually yesterday. The couple, they were so distressed because husband had elbowed the wife quite a few times. He actually elbowed and made a hole in the drywall, and he was in his dreams trying to fight and protect the wife. So that is something you can only uncover when you have an in-lab sleep study, because home sleep tests will easily miss that. So that condition, I think I probably mentioned it in last episode. It's called RBD, or REM behavior disorder, which is another hidden sleep disorders that we're going to talk about in our future shows. So then moving on to narcolepsy and idiopathic hypersomnia, we have to go a step further. The nighttime portion, yes, it'll give us a plethora or a wealth of information, but it still doesn't look at how is my daytime functioning, how sleepy am I getting during the daytime, because really majority of our patients that's what their main complaint is. So if you never really do that test or never really address that problem, how am I as a clinician ever going to figure out how sleepy or tired my patient is? So we do a pretty cool test to uncover that. We call it a nap study, which means you are allowed, or in fact, you're kind of forced to take multiple naps throughout the day. But basically what it is you're given an opportunity to take a nap, and you basically given 20 minutes to fall asleep. And what we're looking at during that study is how quickly is my brain falling asleep, and is it entering into any abnormal sleep pattern through the brain waves that we're recording. And so that happens on multiple naps, basically throughout the day. So we give you an opportunity to nap, and then once that timer is gone, then we wake you up, or you stay awake for at least hour and a half to 2 hours, and then the second nap begins, and the process goes on for up to at least 4 or 5 naps. So that's a much lengthy test, much longer commitment, much longer resources that we're putting into it to test it. So that's why not every lab is even equipped to do that. Not every sleep clinic is equipped to do that. So you have to do some research and see, okay, who are the people who are talking about it? Who are the people who are testing for it? Because otherwise, the example I gave you, if I go to a sleep lab or sleep clinic that's not really focused on that, and all they're caring about is my sleep apnea, and if I don't have sleep apnea, then they're absolutely not the right fit for my condition, so then I gotta dig deeper, go further.
That's interesting too when you said about, they have 20 minutes to fall asleep, but people that struggle with falling asleep, can most people, or can all people fall asleep in 20 minutes? Or like what?
No, they cannot. And that's exactly what we're recording, right? So, because we don't really know whether am I dealing with insomnia, which is difficulty falling asleep or staying asleep, which, by the way, it's a complete another set of problems, and insomnia we tend to bucket, but there are all different kinds of insomnias out there too. There are insomnia folks who only have hard time falling asleep at the start of the night, but once they fall asleep, they have no trouble staying asleep. Then there are others who actually have no trouble falling asleep at the start of the night, but they keep waking up frequently for whatever reason. And then that's my job to figure out what those reasons are. And so that's a different kind of insomnia. And then there are folks who either have their circadian rhythm delayed, where hey, I can only fall asleep if I go to bed at midnight or 1 or 2 in the morning. But if you force me to go to bed at 10, I'm just going to be laying there wide awake watching Netflix or whatever,
Mhm. Right.
and then there are, especially as we grow older, my elderly age group, folks who are retired 60s, 70s, 80s, their sleep cycle sort of it gets advanced, meaning they're falling asleep earlier and earlier. They want to be awake for that 9 p.m. Event, but they're falling asleep at 7 o'clock, at 6 o'clock. So then that's an opposite problem then that we have to fix it to make sure that they're able to stay awake for the times they need to be.
No, that's so interesting. And you also mentioned something earlier about seeing if patients are grinding their teeth at night or shaking their leg and things like that. So those are indicative of like certain specific sleep disorders as well.
That's right. So grinding, it's called sleep-related bruxism. Okay, bruxism just means grinding, but some of these folks are only doing when they're sleeping. They're not grinding their teeth while wide awake. So something triggers that. Sometimes we see it in our untreated sleep apnea patients where they're having this bruxism or teeth grinding. And then the leg movements or leg twitching, sometimes patients don't even realize, but the bed partner is generally the one who is getting disturbed because they're like, oh my gosh, you're just like racing all night long, or you were kicking me all night long, and you're a restless sleeper. And basically what's happening is a lot of the twitching is happening in their muscle groups throughout the night, whether it's from lack of oxygen, lack of iron, and sometimes it's linked with restless leg syndrome, where I gotta move my legs in order to feel calm in my legs. So there are all kinds of things linked to that.
That's so interesting. And for listeners who might be wondering about their own sleep, I know I'm going through my list of things about my own sleep now. I'm like, I think I grind my teeth. But for listeners who might be wondering about their own sleep, what symptom or warning sign should make someone really consider that their fatigue or sleep problems might be more than stress, or their lifestyle might be something to look into?
So that is easy. I think if you are tired, waking up with headaches, or you get tired throughout the day as the day goes on, or you're questioning, it's like, hey, I used to be this energetic person. Why is now all of a sudden I'm dragging through life, right? So sleep tests are readily available. There are all kinds of sleep labs and sleep clinics around you. All you have to do is just take the first step and believe that there are some answers that could be found, and maybe potentially that could be a game changer for your performance, not just at work but with your family life, with your overall sleep quality, and in managing a lot of other stressful situations in life that you might be dealing with. So I would say, for example, my mood disorder patients, uh, don't just keep blaming your mood symptoms, your depression and anxiety, because depression itself is a risk factor for a lot of sleep disorders. So if you're only just focused on your depression and you're not managing your sleep, you're sort of only half treating your condition. We have patients where once we fix their insomnia, their anxiety was gone. They didn't have any more anxiety left because they were sleeping so good. So all the anxiety was being driven by their sleep problems, or insomnia in that case. So
Yeah. That's so interesting because you would like from a non-clinical standpoint, like the way I would be thinking about it, which is probably how most people think about it, is, oh, I have something like, let's say, anxiety or depression or something, and now the sleep disorder stem from that. But in reality, it sounds like it's actually could be the reversed way.
Reverse. And in most cases, it is. And the other beautiful thing is that because sleep problems are quite focused, we can easily find them and we can, for the most part, easily treat them. Not always, but there are always some difficult situations. But for the most part, we have fairly effective therapies out there to tackle these. So it's a sort of a low hanging fruit for majority of us, so that, hey, if I'm struggling, instead of adding that third antidepressant or that third blood pressure medication to my blood pressure regimen, blood pressure pills, why not look into sleep and see if there could be something that we have missed or not uncovered yet? And it's hidden.
Absolutely. And speaking about hidden, this has been a great episode, a great second episode of the Hidden Sleep Disorder Show. I think this was super informative. I know everyone listening is probably going through their their mind about their own sleep and sleep hygiene. But thank you so much for this conversation. And I think today we really explored an important idea that many sleep disorders do go undiagnosed for years. And not because they're rare, but because their symptoms are so often misunderstood. So if you're someone that's been struggling with persistent fatigue, excessive daytime sleepiness, or sleep problems that don't really seem to improve, it may definitely be worth your time learning more about the underlying causes. So if you found this conversation helpful, be sure you follow the show so you don't miss future episodes. If it resonated with you, make sure you share it with someone, share it with a friend or anyone that can really benefit from it. And thank you so much, Dr. Saini.
All right. Thank you, Leila. Take
Have
care.
a good one.